Hello there, this is Tony Breitbach, Director of the SLU AT program. We'd like to welcome you to our MAT Capstone Day, which is the culmination of all of our students' experience in their time here in the professional program at St. Louis University. So we will begin our Capstone Day with our first presenter, who is Jose Blanca.
Okay, so today I'm going to be talking a little bit about different types of stretching. I decided to pick this topic just because I've been exposed to, or we've been exposed to so much stretching in our clinical education and throughout our lives that I felt like it was worth doing a comparative and contrasting review. And I just wanted my goal for this was for you guys to walk out of here with a better understanding on each type of stretching. So at the end of this presentation, attendees will be able to compare and contrast all types of stretching, make an educated decision on which type of stretching it's more beneficial for you guys to pick at the time of creating a warm-up for a team or for any athlete, and then obtaining a better understanding on the use on stretching in general. So stretching has been traditionally used as a part of a warm-up in sports for years. Coaches believe that performing stretching help with reduction of injuries, enhancing performance, and acceleration of recovery. When I first started this project, I came up with two hypotheses. The first one was that all stretching would help with range of motion, no matter the type. And the second one was that all stretching except dynamic stretching would decrease performance in some way. A little background around the topic of stretching is that people use stretching just for the main purpose of increasing range of motion. You can also achieve some changes like muscle and tendon stiffness, passive resistive force, or maximal isometric torque. One of the things why I picked this topic is because there's controversy if stretching really interferes or not with performance. And one of the goals for a warm-up is to increase the body temperature for 1 to 2 degrees Celsius, therefore producing a better muscle compliance and a better muscle performance. So this is a little bit of reviewing of the 5 types of stretching that I'm going to be focusing on. The first one is static stretching, which is when you take a limb to the end of its range of motion without an active contraction. And when you compare that to active stretching, the only difference is that with active stretching, you have an active force production. The other one is ballistic stretching, which is the rapid lengthening of muscle by jerking or bouncing movements. Then you have dynamic stretching, which is a type of stretching where you use mostly sport-specific activities. And then the last one is PNF stretching, which is a combination of both stretching and contraction of the muscle that you're being targeted. There's also little abbreviations after the name of each stretching so that in the future, when I talk about these types, you guys have an idea on which type I'm talking about. For the articles of this capstone project, I focus on articles that have been published on the past 10 years, only written in English. And then I limited my studies only to systematic reviews, meta-analysis, and randomized controlled trials. So for the results, I broke it down in the different types of stretching. The first one is static stretching. Studies showed that it should be avoided if you're trying to achieve higher vertical jump performance. It is beneficial to increase range of motion, but your stiffness and your force generation is going to be decreased. So it's up to you to decide, do I want to use this to increase range of motion, but then also you're going to lose stiffness and force generation. Another thing that I found is that static stretching is detrimental for a number of repetitions, the total volume, the maximal dynamic and isometric strength, and the electromechanical delay. And then lastly, I found that static stretching is effective in reducing eccentric exercise-induced muscle damage in an 8-week program. For ballistic stretching, there's a little bit less information that I found. The first thing that I want to say is that beneficial to increase flexibility when you're doing vertical jump activities. It is also beneficial to increase range of motion, but just as with static stretching, you have the risk of decreasing stiffness and force generation. And then lastly, it decreases the number of repetitions, the total volume, and the maximal dynamic strength. So if this is your goal, I don't think ballistic stretching should be the type that you should be using. For the active stretching, I found that it can be used before vertical jump and sprint activities to increase flexibility. However, I didn't find that many articles on active stretching, and I was pretty surprised because I thought this was widely used on the world of sports, but I guess future literature should focus on including active stretching a little more. For dynamic stretching, this is the type that I found the most, and it's probably the most beneficial part of my study because I found out that it's been associated with stronger muscle contractions. Therefore, you have a better muscular performance, and then the temperature and the muscle also increases. So it is advised that for coaches, dynamic stretching should be included in their warm-up since it provides a stronger muscle contraction. I also found that there's no effect in maximal voluntary or evoked torque production, which is really good. This type of stretching is also unlikely to affect running, jumping, and then the change on direction, which is also really good. And I also found another study that says that when participants were included with either a static stretching or dynamic stretching, they felt like it was more likely for them to perform well. So it might be some psychological effects. It might be that the athlete feels safer, maybe more ready to perform when performing static or dynamic stretching. We don't know that, but the study showed that they feel more likely to perform well. And then lastly, I also found that there's changes in range of motion, and this is attributable to reduce stiffness in the musculoskeletal unit. Finally, we have PNF stretching. And then for PNF stretching, I found that it's beneficial to increase range of motion. I found a couple of articles that actually say that comparing this to static stretching, PNF has been better at increasing, or you can get higher gains in the range of motion compared to static stretching. But once again, the stiffness and the force generation is going to be decreased. Just as with static stretching, PNF stretching is effective in reducing eccentric induced muscle damage, for example, in an 8-week program. And then lastly, this type of stretching should be avoided if you're using it to increase vertical jump performance, limb velocity, movement time, maximal dynamic strength, or the number of repetitions, or the number of, or the amount of total volume. So just to make the results in a more compact way, I labeled them in different bullet points. The first one is, although all types of stretching improve range of motion, it can also be detrimental for the athlete. As I said before, static stretching, ballistic stretching, and PNF stretching have some negative effects, if you should say. So it's really up to the clinician to decide, like, okay, do I really want to use this type of stretching and have these side effects? Or do I want to use another type of stretching? It all depends on the demand of the athlete. Dynamic stretching does not affect maximal voluntary contraction or torque production, which is good. Coaches can really consider including this on the warm-ups because we want a stronger contraction on the athlete. And it is advised that coaches include this on their warm-ups. A thing that I found about dynamic stretching, like the literature on this type of stretching, is that there's no specific protocols. So we have no rules, protocols, or methods on how to use this type of stretching, at least right now. So for future references, I feel like researchers should focus on creating like a protocol on how to use this type of stretching. Finally, chronic stretching does not seem to change neither the properties of the muscle or the tendon, at least on a 3 to 8 week program, more of like a chronic type of setting. Adaptations to this time frame, which is like around 8 weeks, are mostly attributable to the sensory level. So it's mostly, sensory changes than anatomical or functional changes on the body. And then I didn't find studies comparing all the 5 types of stretching. So I really think that future studies should focus on really bringing them all together. I found that warm-up should include a aerobic activity followed by dynamic stretching, followed by sport-specific activities. There's a couple of studies that say that this is a way to go and this is a way to enhance the muscle performance of the athlete. And then just to close off this presentation, I think that whenever you're picking a stretching type, it should be picked on the demands and the goals on the patient. If you really want to increase your range of motion, you can pick any type. However, if you want to be careful with the number of repetitions, the total volume and all the factors that I mentioned before, then you should maybe just not include, static, passive, static, active, ballistic, and PNF stretching, but you should consider using dynamic stretching. Therefore, it's up to the clinician and to the patient to decide, okay, what's my goal? What type of stretchings I have? And do I really want to benefit from increasing range of motion and then losing other factors? Or do I really want to increase in other factors and not care too much about range of motion? In conclusion, all types of stretching are effective in improving range of motion. There's no doubt about that. Some articles say that, either this type or this type is more effective. It's just different. It varies by articles, but all of them are really effective in improving the range of motion. Static, ballistic, and PNF stretching should not be used before the exercise if your goal is to produce maximal force production, number of repetitions, or the quickness of the contraction of the muscle. And then finally, dynamic stretching has been shown to improve muscular performance by providing stronger contractions. Therefore, it should be included on the warm-ups by the coaches. And then future studies should really create specific protocols for this type of stretching. I would like to thank the department because the courses that they offered here inspired me to work on this project. These are my references if you guys are curious to see where I got my information and go in depth into these studies. And this is my contact information if you guys want to ask me any questions. Other than that, if you guys have any questions, please let me know.
Any questions?
There is one question in the chat.
Okay.
The chat question is from Timothy Hull, and he asks, can you please elaborate on the concept of electromechanical delay and its relevance to stretching?
So what I mean, Tim, good question. What I think I meant for electromechanical delay is the rate of the contraction of the muscle. It's more of the neuromuscular level. So what I meant was more of a, if you lose electromechanical delay, means you're kind of losing the quickness of the contraction, and this might be detrimental in the activities that you are doing. Whether you're jumping, whether you're running, you want to have as quick of a contraction as you can. So thanks for the question. Tony?
I have a question. When you talk about decreased stiffness, describe that term stiffness. Is that something that is a positive to have increased stiffness in a muscle, or because stiffness is used in several different ways?
Yeah.
When you talk about stiffness, is it something that decreasing stiffness is a positive or decreasing stiffness is a negative?
I think that's a very good question, and I've asked that to myself before. And I think it just depends on the athlete and the demands. Like if you have a lot of stiffness, meaning the muscle has less compliance, the muscle is less likely to deform and to undergo changes. That can be good, but that can also be bad because if the muscle is too tight, then you can, create a damage to the muscle. And if you're in the other end where you don't have that much stiffness, then this can be good for activities that you want high range of motion. So it just varies on the patient. It can be good and bad. Once again, it depends on the goals of the patient. I hope that answers your question. Yeah.
Any
Anyone
other
else?
questions? Classmates?
No.
Questions?
Thanks.
Jose, can you go back to your very first slide?
Oh, okay.
I didn't get my
Photo.
dorky picture. There we go. Yeah, there we go. Ready? Okay.
Yeah.
Okay, then go to the beginning of the next one. Okay. what we're going to do is we're actually going to introduce the next, you're going to introduce the next person, but first we want to say congratulations to Jose. Good job. This is the next person.
Okay, so coming up next, Maddie is going to talk about returning to Division I men's basketball after battling with COVID. Maddie's been with the SLU Billikens for the past year, and I'm sure she has interesting things to say. Welcome, Maddie.
Let's get a picture before we start.
Okay. Yes. Alrighty, so thank you, Jose, for your introduction. I'm doing my capstone presentation on returning to Division I men's basketball after battling COVID-19. By the end of this presentation, I hope you will be able to understand the need for a return to play protocol following a positive COVID case, understand heart rate and how it can be used as an object to measure in physical activity, and customize return to play protocols based on sport-specific physiological needs. So we all have been living through COVID for the past year. It definitely left many uncertainties about normal life, let alone college athletics. The CDC was the governing body of information and guidelines, and they did give a lot of guidelines on prevention and what you do once you contracted the virus, but there weren't as clear guidelines on what to do after you have recovered from the virus. So I was fortunate enough to be with St. Louis University men's basketball team for my clinical rotation this year under Jonathan Birch. And we were fortunate enough that our season did go on as the first season we played since COVID. And although we followed very closely in prevention measures, which could have been a whole other presentation in and of itself, there was an inevitable breakout within our team. So this project is just looking at how our athletic department handled returning our athletes safely to participation. The protocol that our team physicians decided on comes from the British Journal of Sports Medicine. This is the original protocol that comes straight from them. As I'll talk about later, we changed a little bit of, not necessarily changed, but made it more specific to basketball in some of the sections that were left a little bit more broad. When I saw this, I was inspired to ask the question, why as many steps? Why were we looking at what we were looking at? Why the different levels of heart rate? And to understand those whys, I looked at the COVID-19 etiology. I wanted to understand heart rate more, and I wanted to look at the physiological demands of the sport of basketball. What I found about COVID-19, I wanted to focus mostly on the after effects. I didn't as much focus on the during effects, but it is a severe acute respiratory syndrome that is spread primarily via respiratory droplets from close face-to-face contact. Obviously, there's a lot of that in basketball. It can be spread asymptomatically, pre-symptomatically, and symptomatically. And the average time from exposure to symptom onset is 5 days, but can be as long as 14 days. And this will come into play a little later when I explain our team's personal outbreak. The most common symptoms are fever, dry cough, and shortness of breath, along with a bunch of other stuff. When it comes to fighting a virus, your immune cells defend by releasing small proteins called histamines. So this will cause inflammation, which in turn causes symptoms such as body aches, coughing, sneezing, and fever. But the positive of this inflammation is that it allows your blood vessels to expand and become more permeable. In turn, this allows white blood cells and proteins to come in from your blood and help damaged tissue fight infection. When your blood vessels expand, there are signals sent to your brain that increase your heart rate and pump more blood to the inflamed regions. Again, just creating a cycle of more blood equals more white blood cells and proteins. Two things that were talked a lot about in the news regarding the after effects of COVID were myocarditis, which is inflammation of the heart, and persistent respiratory problems. So these are two issues that need to be looked at when getting cleared from COVID. And so to specialize our protocol based on basketball, I wanted to look at the physiological demands. So basketball is a sport with periods of very high intensity activity. mixed in with low to moderate activity. And this is usually a fast transition in games. The types of movement patterns are running, jumping, shuffling, etc. And specifically in a 40-minute basketball game, it's been found that athletes will travel 5 to 6 kilometers in average physiological intensities above your lactate threshold and hit 85% of your max heart rate. Heart rate is how many times your heart is beating per minute to transport blood throughout the body to supply oxygen, and it is a component of the central nervous system. This breaks down into two other components: the sympathetic nervous system, which is your fight or flight response to stress. This is when your pupils dilate, you increase your sweating, you increase your heart rate, and increase your blood pressure. The parasympathetic nervous system is your resting and digesting, which basically undoes the work of the sympathetic nervous system, decreasing respiration and heart rate. In a healthy individual, these two systems work together to maintain you in balance. Heart rate is great because it can be used to view how the heart is working during exercise. There's not a lot of concrete ways to look at how the body is working in the middle of practice. So this was a great objective measure for us. A higher than usual heart rate pattern during training may be signs of residual fatigue from accumulated training. So if you have a higher heart rate, it could be you just worked too hard, too many days in a row. Also going back to COVID, if you're having a higher heart rate than you should, it could also be signs that your body is still fighting the infection. As we kind of talked about, your heart rate will increase during that. In a study of elite under 19-year-old basketball players, they found that the mean heart rate during basketball activity was 171 beats per minute, which is very close to what I found during our study. And it is important to note that a more well-conditioned athlete will have a lower heart rate during competition compared with baseline. A side note, it's very important to take baseline measures, which most universities do, but this will indicate a successful cardiovascular adaptation through suppression of that sympathetic nervous system. The heart is a muscle, so the more trained it gets, the better it is at pumping blood throughout your body and has to do it less. As I mentioned before, this protocol comes from the British Journal of Sports Medicine. The sports specialization was done in collaboration from the head athletic trainer and strength and conditioning coach. For our athletes, they were quarantined 10 days from their positive case and seen by a team physician to be cleared. This clearing was basically just like a pre-participation exam with more focus on lung sounds, listening to the heart, and it also included an EKG. The protocol also had the contingencies that the cases were mild to moderate. They should have at least 10 days rest and be 7 days symptom-free and be able to complete activities of daily living. An important note or interesting factor in our outbreak was that we had clumps of positive cases, so not all of our positive cases were on one day. So when we were following this protocol, we had to really keep track of who was on what day. And sometimes we were executing day 4, 1 hour, and then the next group would come in and they would still be on day 2. I wanted to specifically look at one of our athletes to get more of a subjective side in addition to objective measures. And my premises of picking this athlete were that they had no major previous illnesses or comorbidities that might affect some of our data. Also, I looked at the time that they would play in games. So I wanted to make sure this is one of our players who played a lot of minutes because I wanted to make sure that this protocol was serving our highest level athlete. He ended up playing 32 minutes out of a possible 40 in our first game back. And when we were doing this progression, our athletes wore a heart rate monitor around their chest, and it was Bluetooth to an app on our iPads. My specific athlete was a 22-year-old male. So if you calculate, for example, 80% of his maximum heart rate was 158 beats per minute. But basketball is high and low intensity, so we gave him a range. With all of our athletes, if they got anywhere close to 180, we would just walk over with our iPad and just pull them. Everyone else could keep going, but we would just pull them until their heart rate got back down, which was nice that this heart rate was so convenient. This is the exact protocol that we use based off of the British Journal of Sports Medicine. The comment section is what we mostly changed, but as you can see, it starts very low activities of daily living and progresses in 15-minute increments. Also, day 2 starts at 70% of your max heart rate, but days 3, 4, and 5 are 80%. We did a lot of biking for cardio, and then shooting, which was sport specific, but also threw in some cardio, which just progressed as we went along. We also threw in weights because regardless of a virus or not, if you're a Division I athlete sidelined for 10 days, you're losing your physical ability. So we wanted to make sure that we could get them to where they needed to be to play a game. I interviewed my specific athlete to kind of get his personal experience. He was symptomatic. So the first day he had chills, and then for about a week, he had just not feeling like his normal self. He felt sluggish and was short of breath. He described to me that he enjoyed the progression. He thought it built up nicely. He noted he definitely would not have been able to just jump right back into practice, but he did note that he felt very tired in the first game, and that practice just can't really replicate a game. So what we can take from this review is that return to play progressions are very important. There's a lot of focus on them with musculoskeletal injuries, and we see a lot with concussions. But personally, I have not seen a lot with illnesses. So I think if COVID has taught us anything, it's what a virus can do to your body. So this can be definitely used in the future with our athletes. I think also we can take away the high benefits of a heart rate monitor and just monitoring our athletes. Sadly, also, I don't think COVID is going to disappear. So this protocol could be used for quite a while. In conclusion, I found that our 6-day progression, closely monitored by heart rate, is the best course of action to return to sport. I found that the protocol was very accurate in its buildup. As I noted before, the average heart rate of 171 beats per minute. If I calculated this with, again, my sample athlete, this would have been between 86 and 87% of his max heart rate, which fits well because the day 3, 4, and 5 were 80%, leading him to that 7th day of normal practice, which he would hit that 86%. And then lastly, progressions are great, and they get the athlete back to the best they can, but they're still difficult to mirror game intensity, which is just something to note. I would like to thank Javante Perkins for being my case subject. I would also like to thank Jonathan Birch and Rob Hornet for being the certified professionals overseeing the progression, teaching me, really educating me on why we were doing what we were doing. And then also thank you to the athletic training program. Here are my references, and thank you very much.
Questions, anyone? I have a question. So you did not comment whether or not they wore heart rate monitors when they played games. Do they?
No, but they continued wearing them the rest of the season. So that was, oh, and we did not give them a choice. They had to wear them during the progression, but if they wanted to continue to wear it afterwards, they could. A majority of them did, but a handful did not.
It's like mouth guards.
Yeah. But yeah, that was very interesting.
Any other questions for Maddie? Did you do much testing?
Yes. So I was very fortunate to be certified in PCR testing as well as the rapid antigen testing. We started during preseason doing twice a week through the student rec center throughout the student testing. And then once we moved into our season, we tested 3 times a week, and that fell on us, the athletic training program. So we got to take a big role in that, which was very educational and very nice. Yeah.
Okay, good job. I'm going to click the slide and then introduce the next person.
Okay, so next up is Kate Perko, and she is going to be talking to us about athletic trainers and practicing what we preach.
Okay, So yes, the title of my presentation today is Athletic Trainers Practicing What We Preach. It's Mental Health Awareness Month, and this presentation goes right along with that topic. So, at the end of the presentation, attendees will be able to identify 3 coping behaviors demonstrated by both athletes and athletic trainers, discuss the risk factors of each coping behavior, and then describe intervention strategies for each coping behavior. So the inspiration for this project came actually from one of the IPTS seminars, which was a interprofessional seminar with med students, PA students, nurses, athletic trainers, physical therapists. And during some of the downtime, one of the pharmacy students and the med student started talking about what he had been up to, the med student, and he had said that he just finished a 24-hour shift and he was really ready to take sleep. And I was like, surely that affects patient care, was my initial thought. And then as I was doing this research, I came across this statistic of, as of 2016, just 5 years ago, more than 14% of nurses had smoked cigarettes in the past year. And nurses very well know the dangers of smoking cigarettes. And so it raised the question of, how do athletic trainers compare? What kind of behaviors are we partaking in that we educate our athletes on, and why not to do them? So on the other side of this is my other inspiration was COVID-19 and other critical events. So COVID-19 has been a chronic stress on athletic trainers throughout this year and more. And then critical events could be considered acute on chronic stress events. These include things like sudden cardiac death and other emergency situations such as exertional heat stroke. And also things like, what if an athlete or student is involved in a motor vehicle accident, or if there's a death of an athlete or a student within your school. These are very stressful events that athletic trainers often provide care for and support for. And I wanted to know how ATs cope with these high levels of stress, and then can intervention tools that ATs use for their athletes also be used for ATs themselves. So a little bit of a spoiler alert, from my research, I found some behaviors were binge drinking, disordered eating, and burnout in athletic trainers. And so some background on binge drinking. Binge drinking is a pattern of drinking that brings a person's blood alcohol level to 0.08 or above, and typically occurs in men after they consume 5 or more standard drinks, and women if they consume 4 or more standard drinks within 2 hours. Some risks of binge drinking include memory loss, increased blood pressure, stroke, heart and liver disease. Disordered eating is a disturbed and unhealthy eating pattern, and includes things such as restricted dieting, compulsive eating, or skipping meals. And partaking in disordered eating decreases your ability to cope with stress, and also increases the incidence of suicidal thoughts and behaviors. And then lastly, burnout. Symptoms of burnout include exhaustion, alienation from work-related activities, and reduced performance. This burnout also increases the risk of depression, and depression leads to low self-esteem, hopelessness, and suicidal tendencies. So when someone says that they just skipped a meal today, I should hopefully pique your interest, because there might be a lot more going on and things that are a lot more serious going on. My methods for this study included a literature review of the Journal of Athletic Training, because I wanted to specify athletic trainers. I found 33 results using the term athletic trainers and substance abuse, and excluded everything but research articles. From there, I identified these 3 risk behaviors that have also been identified in athletes, and then compared rates, risk factors, and prevention and intervention measures. So my results for binge drinking. So athletes were more likely to partake in binge drinking at greater rates than non-athletes. And these rates included 57% in male athletes and 48% of female athletes engaged in binge drinking within the last 2 weeks for this study. Risk factors included being college aged and what peer groups they were involved in. As for athletic trainers, from a study that was done about alcohol use in athletic trainers, approximately 46% of the sample engaged in at least one binge drinking episode in the previous month. And risk factors are very different than athletes, at least college age athletes. and include burnout, catastrophic event, emotional exhaustion, decreased sense of personal accomplishment. So much, very concerning. Disordered eating. So this statistic came from the National Athletic Training Association position statement about disordered eating. And they claim that the prevalence estimates that it ranges as high as 62% among female athletes and 33% among male athletes, which is very high. I should specify disordered eating is, as I listed before, like skipping meals, restrictive dieting, use of laxatives, binging, eating. And so these are not clinically diagnosed eating disorders such as anorexia or bulimia. Risk factors that athletes have include pressure to manipulate eating and weight for performance and appearance, sociocultural and media emphasis on thinness, and the athlete's perception of what is required to optimize performance. A statistic that I found to be absolutely astounding was that 84.8% of ATs within this study presented with eating disorder risk. And again, these are not clinically diagnosed eating disorders, but this includes risk behaviors such as skipping meals or having a negative energy balance. And risk factors for this include interpersonal insecurity, interpersonal alienation, emotional dysregulation, perfectionism, and maturity fears. Burnout rates in athletes. So one study, about 1 to 2% of athletes in a sample of 980 were experiencing symptoms of severe burnout, which implies burnout is a serious problem among competitive adolescent athletes. And this is also to say that this is just 1 to 2% were experiencing severe burnout. So a greater number, a greater percentage were probably experiencing mild or moderate symptoms of burnout. And to go back to the point about athletic trainers, 84% of athletic trainers have an eating disorder risk. It's well within the possibility that a percentage of those do have undiagnosed eating disorders. Just food for thought. Risk factors for athletes experiencing burnout include excessive time commitment, demanding performance expectations, frequent and intense competition, little personal control in sport decision-making, perfectionism, non-assertiveness, and unidimensional self-conceptualization. I have a phone alarm going off during my own presentation, so sorry about that. All these risk factors, I believe I can also relate them to an athletic trainer, but on top of all of that, athletic trainers' risk factors for burnout include exposure to catastrophic events, emotional exhaustion, low personal accomplishment, work-family conflict, and role strain. And therefore, burnout doesn't have a very specific definition. It's still debated, but as far as symptoms of burnout, about an average of 20% of ATs studied have experienced either emotional exhaustion, depersonalization, or low levels of personal accomplishment. So from these two, to compare these two populations of collegiate athletes and ATs, both had over 40% of these populations engaged in binge drinking within the previous month. And so binge drinking often occurs with social drinking, and not to say that we should go out and have a drink to celebrate, but when it becomes excessive, it needs to be looked at a little bit more closely. Social drinking is a great way to network, reconnect, and relax with colleagues and friends. But when that becomes very frequent, or even behaviors of dependency arise, it needs something needs to be said. And so we are well aware, or we are absolutely capable as athletic trainers to get involved during these things. It falls within domain 1 of injury prevention and wellness promotion. And so these two studies were specifically talking about the college setting, and college athletes are required to take more university alcohol safety courses than the average student. And ATs are often involved in these alcohol safety courses in some manner. So it raises the question of how much are we paying attention during these meetings, and can we also apply these strategies that we're educating our athletes on to ourselves and our colleagues. So disordered eating is often about seeking a level of control. We athletes and ATs don't often have control over the schedules that we keep or the injuries that our athletes end up having, and that can be very difficult sometimes and increase the workload unexpectedly. There's also an clear sociocultural emphasis on thinness that everyone experiences every day. Just look at Instagram, and that applies to both populations. So the NATA position statement, as I mentioned before, on disordered eating offers some recommendations for the initial intervention of an athlete suspected of having an eating disorder. And this includes the initial intervention being conducted by an authority figure that has rapport with the athlete. And then that person should approach the subject with sensitivity and respect. They should indicate observations of concern, expect denial, anger, or resistance from the athlete, and then be prepared to make a referral. Now, I see no reason that these 5 steps cannot also be used for athletic trainers who have a suspected habit of disordered eating. The question then becomes, who is the authority figure? Because often we are the authority figure for our athletes. We have rapport with our athletes, but for us, does that mean it's a colleague? Does that mean it's a supervisor? Who feels, does it even have to be an authority figure, or can it be a friend? So things to think about. Now, burnout, as I mentioned several times before, include decreased personal accomplishment, emotional exhaustion, and depersonalization of patients. And this can manifest as binge drinking or disordered eating to cope with burnout. Now, we have youth recommendations for burnout in youth athletics. We are all hopefully very aware of it at this point, and to prevent burnout in athletes, we recommend delaying sport specialization, taking time to rest from sport activity, and then receiving adequate sleep. And so ATs can't exactly delay sport specialization, but we can get adequate, we can use our paid time off, and we can set boundaries between our work and our personal life. The NATA has also put out a position statement about facilitating work-life balance, and I would recommend everyone take a look and apply some of those strategies to ourselves. Okay. Now, this has been a big conversation about mental health intervention, and Young et al. Conducted a study on collegiate athletic trainers that found that less than half of their respondents were fairly confident in screening for mental health risks, implementing preventive patient education, and recognizing mental health conditions. 46% of respondents indicated that they were very confident they could refer mental health emergencies. And when I see this, all I have to say is that we can do better than this, and we need to do better than this for our patient population. Less than half that are fairly confident in recognizing mental health conditions needs to be improved. And I think we can also start with ourselves and being able to recognize it within ourselves and our colleagues. And so the National Institute of Mental Health defines serious mental illness as a mental, behavioral, or emotional disorder resulting in serious functional impairment, which substantially interferes with or limits one or more major life activity. Emergencies are classified as major when there is danger to life, either of the patient or to others in their environment, or minor where there is no threat to life but causes severe incapacitation. Now, disordered eating and binge drinking fall well within the definition of a minor emergency, as they do and can cause severe incapacitation. And minor emergencies can very quickly turn into major emergencies. And then all of a sudden, we are no longer dealing with domain 1 of emergency or of illness prevention, and we are now talking about domain 3 of immediate and emergency care. So ways to improve this in our program would be to create policies within our employment companies to be aware, to set up guidelines of how to facilitate these discussions, training guides, and such things, so that we can improve our own education and hopefully recognize these things within ourselves and our athletes. Lastly, on a bit of a lighter note, there's a light at the end of this tunnel, is AT's Care. It was developed in 2014 by the NATA, and it is a peer-to-peer support program to assist members in the aftermath of a critical incident or catastrophic event. And they offer Training opportunities for ATs to enhance their knowledge of crisis intervention to equip them to support their peers. I think this is a great program, and everyone should check out their website on the MATA webpage and get involved in some way or take a class in some way. Limitations and future research. So I was definitely limited by the variety of populations, sample sizes, and definitions used in previous literature. This hasn't been dug into that deeply. And so for future research, I would hope someone will, or myself will survey across or conduct a survey across one setting to identify how ATs cope and what kind of coping behaviors they rely on, and then identify what resources are available to ATs following crises. So due to workplace stress, athletic trainers are at risk of developing risky coping behaviors, including binge drinking, disordered eating, and eventually experiencing burnout. And athletic trainers have the skill set to reduce the rate of each of these risky behaviors by increasing awareness of the problem within the profession and supporting their colleagues during mental health crises. We are all about to be new graduates, and we will be experiencing stress that we could have never imagined within the next year. And I just hope this presentation helps each of us support each other and look out for each other as we go through this next phase of life. Thank you, Tony, for being part of this presentation, and thank you to all of my family watching. Thanks for the support. These are my references, and if you'd like to reach me.
Have you see any any results that show that these behaviors and stuff are going down in the recent years, or did you see anything like that?
No, just because of how few the articles are on these topics, they haven't been able to do follow-up studies yet either. There's usually there's one that I was looked at it in high school athletic trainers and looked at it in college athletic trainers, but haven't done the follow-up study to see if there's been any intervention that has worked.
On the athlete side of binge drinking,
Oh God, I'm so sorry about my phone.
did you see a lot of data between in season and out of season?
Again, no.
Yeah, I think a lot of the research that's been done lately is kind of the transition of practice.
Mhm.
I think, as you work in this area further, I think this is more of a comment than a question, but I think there's been a lot of research around kind of the intent to continue in the profession.
Mhm.
And a lot of that happens within the first 5 years and has
Yeah.
to deal with these types of issues. So I think as new grads, I think it's important that, you get yourself in situations where, you have a support structure that can help manage this.
Because we are always looking out for our athletes, but what if a fellow athletic trainer starts talking to you about how they were so hungover multiple days in a row, and are you going to say something or do something about that? Thank you. Thank you. Next up is Joshua Hicks, and he will be talking about the effects of weightlifting belts on the core ability to produce IAP.
Quick picture. for this.
Yep. That's good. Okay, I'm Josh. I'm going to do, I did a study on the effect of weightlifting belts on the core's ability to produce intra-abdominal pressure. At the end of this, you should be aware of the varying opinions on wearing the weightlifting belt and some of the research there is and the lack of research. And then you should be able to describe how a weightlifting belt could possibly affect the athlete's gains and form. And then you'll recognize and see the need for future research. I did a case study, so it's just on one participant. This is kind of a pilot study to kind of figure out what works for the future, because eventually I want to try to make this into more of a randomized controlled trial. But what got me interested is throughout high school, I was a wrestler and football player, and we always had a heavy weightlifting regimen, and a lot of people would use weight belts, wouldn't, and there's like just talks of whether you should or not. But the kind of idea behind not wearing them is that like weight belts will not allow your core to work as much, and so it'll become a little weaker compared to like the rest of your muscles as they're getting really strong from the squats and stuff. And then the pros, I guess, for wearing a weightlifting belt would be that it like stops your hernias. It will it'll keep your back from hurting. Just like that's the general thing where just like opinion, not necessarily stated fact. But how does this apply to athletic training? So what you do in the weightlifting room can like affect you on the field. And so when you think about the abdomen and like the pelvic floor and your intra-abdominal pressure, if you are strengthening all your extremities and then letting this get weak, when you go out to the field, you're not going to be able to stabilize your spine as much. And it's just going to open you up for injury out on the field, which is what as athletic trainers we deal with. So why is intra-abdominal pressure important? It, like I just said, it allows us to stabilize that spine. It gives the trunk like a solid base for us to move our extremities. So it can help you perform better and just injury prevention. But how we produce it, pressure is produced by having the same volume in a certain space, and then the surrounding things kind of compressing to create a harder pressure. And so that's how we create that. We have our diaphragm, we have our abdominal muscles, especially our transverse abdominis, our pelvic floor, and then in the back, the multifidus. Those will like shrink, but then we'll keep the same amount of volume in there, and it'll just increase this pressure that stabilizes that spine. But what current research shows right now is that during the squat and deadlift and power clean exercise, the electrical activity of the abdominal muscles and some in the multifidus and stuff, those actually increase the electrical activity. But what and overall intra-abdominal pressure is a little higher during the activity when we wear a weight belt. But what we don't know is if that actually helps us gain more muscle so we can use that out on the field or not. Because if you think about it again, how pressure is made, we don't know if that we're hypertrophying those muscles so that they can shrink and make that space and pressure higher. But yeah, and again, this is they've only done research with the weightlifting belt in the weight room. There's not a lot of research that takes this idea and see how it affects the outside of the lifting weights. So my case study, I had a 24-year-old female softball player. She has lifted all her life, so she's pretty experienced in that. But I split this case study into two phases, really. We would do base testing. We would have a lifting phase where she wouldn't use a belt. And then we did another base test to see how she gained, like how her core muscles gained in that first 4 weeks. And then we did a second 4 weeks of her using a weightlifting belt during like a small like football simulated workout stuff. And then we would do another base testing at the end to see how wearing the weight belt affected our muscles. Yeah, so we did like a simplified high school weight training regimen. We split it up into 2 days a week. On our first day, we had our squat, bench press, and shoulder press, which we only recorded stuff for the squat. And then on day 2, we did our deadlift and power clean and pull-ups. And we recorded the deadlift and power clean stuff because those are the important ones. And then all the lifts were done at 3 sets of 5 to like kind of simulate a strength training regimen. And we were trying to get her to get an RPE of 9. Anywhere from 8 to 9 was good, but we really wanted to keep it around 9. And then for lower body lifts, so like the squat, deadlift, and power clean, or just squat and deadlift, we try to do 10 pounds a week. Because I know if you go to a lot of high schools, just in my experience from my clinical sites, they try to increase it a lot because they have a short amount of time and a lot of athletes. So 10 pounds a week for the squat and deadlift, and then power cleans, we did 5 pounds. And then our upper bodies lifts, we did 5 pounds a week. And then we also took a video from the side to see how this weight belt was affecting her form. So like see if her hip angle was decreasing or increasing. But in case some of you guys, there's like a ton of different power cleans. So I just want to show you, or different types of cleans. So I want to show you what a power clean was that we did. So it was like this. But so the testing methods that we used at the beginning, middle, and end, we use an isometric hold. And so we did a plank, a side plank, and then a lumbar extension hold to test like the front, side, and back of those trunk muscles. And then to get like a intra-abdominal pressure, we use a belt and we put a blood pressure cuff during like each. So during the plank, we put it in the front. During the side plank, we put it in the side. And then during the extension, we put it in the back to see like how those muscles were able to expand and like create pressure. And we also use an RPE just to make sure she was giving everything. Like we had a better idea of how hard she was trying on this stuff. But there you can see the bottom left picture is the extension. And what we would do is we'd have someone sit on the back of her leg so she could maintain that straight body. But yeah, we got the plank, side plank. And then on the bottom right, you can see that we made sure that it was a loose fitted belt so that it didn't like help her in any way. So our results, we, like I said earlier, we just compared our base test to the middle to see how much without a belt she improved. And then we compared the middle to the end to see how much she improved with the belt. And then I compared those two results at the end. And then we just watched the videos, and we had this little angle tool, and we figured out her angles on her like hip to see how the belt changed your form, because that's also going to change how your muscles work. Here are the results. So overall, she was able to increase her isometric holds better while training without a belt. You can see like they increase a lot, like 52 seconds on the plank and 32 and 53 on the side plank and extension. The cool thing was that her intra-abdominal pressure on the anterior side increased when she wasn't wearing a belt. But when she trained with a belt at the end, she was able to increase her intra-abdominal pressure more from her lateral and posterior muscles. So like, so with the belt, the anterior increased, without the belt, the anterior increased, with the belt, the lateral and posterior increased. And then her hip angles actually changed a lot with the belt. She kind of was in a more forward lean while wearing a belt. So you can see that like during the deadlift, her hip angle was 60 compared to during the deadlift without a belt, her hip angle was 67.6, and then same with power clean. But so for future research, I'd like to get a little better tools. So like the intra-abdominal pressure method that I used wasn't necessarily the best. I mean, it was what I had. But I'd like to do rectal intra-abdominal pressure. That's probably like the gold standard outside of vaginal, but I'd like to test this on male and female, and can't really do that with male. I'd like to add a force play and then more angles for the video just to see how much more the belt will change her lifting form. And then I wanted to add an EMG readings to outside of the lifting to just see how those are affected outside the weight room, because they only have EMG readings while they're wearing the belt in the weight room. And then to really see this, I'd like to do dynamic movements instead of just those isometric holds, because that's like sports all dynamic movement. It's not going to be just sitting there for the most part. And then there's a couple studies that had ultrasound imaging, but they never could get it to work because they just wouldn't get a good reading. They try to ultrasound while they were deadlifting and stuff. So if there comes a way that we could do that in the future, that would be perfect to see if those muscles are actually shortening rather than just being an isometric thing. It also needs to be a randomized control trial, because she kind of got burnt out to the second half of the 8 weeks. So she started failing some lifts, because like 8 weeks on that intensive a workout is a long time. Like it's pretty hard on anybody's body. And then like in the first 4 weeks, we had to figure out what lifting program she was using or what weights she would use for the lifting program. So it kind of threw off the results a little bit. And then a progression curve. If you lift for 8 weeks straight, you're not going to be able to keep that lateral curve. You're not going to keep improving 10 pounds every week. You're eventually going to start to level off. And so if we split that up into two groups of multiple people, we'll be able to do it for a shorter amount of time, and we'll be able to compare them without like the burnout and then the finding the weights in the beginning. But for education and practice, I mean, figuring this out will just help us do what's best for our athletes when they go out on the field, because using what's in the weight room to take them out in the field and prevent injury, because when that spine is stabilized, they'll be able to just be healthier, and that's our whole job. And then we can also kind of target what muscles we want to use more. If our back muscles are more engaged when we're using a bell, someone maybe has a strong core, abdominal muscles, has more of a weak back, then we can tell them, hey, wear a belt while you squat, and we'll strengthen those. It'll help us strengthen those up. But yeah, that's why we could use that in future practice, and then just educate people. So like all the things you hear in the gym, like, hey, if you do this, then you'll get like these extra gains. We can kind of put studies out there to prove some of the myths, false or true. So like with wearing a weight belt, does it really weaken your core? Yeah, so just future research is needed. What I did find with this is training without a belt, you get the overall greater isometric holds, and then your anterior muscles will be worked a little more. But training with a belt will allow you greater lateral and posterior muscle activation, which that could be due to form, it could be due to just overall muscle. But anyway, I want to thank Susan Hicks. She was the test subject. She last second, someone I had lined up to do this. He got COVID last second, and I had to get this study going because it's an 8-week thing. And she jumped in right away, and she's a teacher. She coaches softball, and she was able to sacrifice some time to get in there twice a week for me. So that was nice. And the lifting program was intense, and it was pretty hard. She was pretty burnt out by the end of it, but she stuck through it. And then Dawn Cunningham is my boss at the Y, and she allowed me to actually conduct some of these experiments while I was at the Y working, because I just had a very busy schedule. I'd be at clinical and then go straight to the Y. And so she said I could do that. So that was nice. There's my references, and this is how you can contact me.
Questions?
We have one question in the chat. It's from Tim Howell. It says, did this athlete progress her lower body lifts by 80 pounds in 8 weeks?
She did on the deadlift, actually. She did fail on like the last squat, but yeah, no, she actually did on the deadlift, which is pretty impressive. Like you could see it in her musculature too. Like she just overall, her legs were getting a lot bigger and stuff. And yeah, it was pretty impressive.
So John, just for clarity, what did she start at?
I have it all written down. I think she started at, so her RPE at the first ones, we tried to find a way to put her at like a 7 or an 8 so she could keep progressing. And I think she started off somewhere around 135 pounds around on the squat and deadlift, and she was up to like almost 225 at the end. It wasn't quite there, but yeah.
So I think, so you may attribute some of those differences also to the fact that, you know, the progression, your improvement, you plateau a little bit.
Yes.
And so it'd be interesting, at least, even if to replicate the study, is to reverse it and to do the belt first and then without the belt after. And take a look at it.
Yeah.
A simple way to retest it. But
Yeah.
I'm not sure if your subject will volunteer to do it.
Yeah. Yeah.
Okay, good job. That's it. Sure.
All right, next we have Gabby, and she's going to talk about the importance of sickle cell awareness in athletics.
Do a quick picture here.
Okay, all right, so today I want to talk to you guys about sickle cell awareness and athletics. So by the end of this presentation, the attendees will be able to recognize signs and symptoms of a sickling event, understand the necessary equipment to have for sickle cell disease and sickle cell trait athletes participating in sport, and also understanding the importance of pre-screening athletes before activities to decrease sudden death in athletics. Okay, so I want to start off with a couple of just some stats that I found that I thought would like spark you guys' interest a little bit. So this past year in the United States, there were 8,480,000 high school and collegiate student athletes. It was 60% of those athletes in the United States were in the college setting were African Americans. And another fun fact I found was 1 in every 12 African Americans are born with sickle cell trait, and 1 in every 365 African Americans are born with sickle cell disease. So sickle cell anemia is a red blood cell disorder where there isn't enough healthy red blood cells that effectively carry oxygen throughout the body. Somebody who has sickle cell trait only has one of those genes, and somebody who has sickle cell disease has both genes present. Where the actual technical name for sickle cell anemia gene is a hemoglobin beta gene, and it's found on the chromosome 11. So with this picture to the left with the red blood cells, that shows a healthy individual with no sickle cell trait or sickle cell disease. And the one to the right, if you can, is there a pointer on? There's, ooh, what did I do? I don't know. So I'll just use this. So right here where the mouse is, that's where the sickle cells are. And you see how it's pretty blocked on that vessel. So you see this little line right here. We have like the regular red blood cells kind of having a hard time getting through that vessel. So technically a sickle cell gene or sickle cell is a rigid and sticky cell that is commonly gets stuck, like I just explained, into a small blood vessel. They are like that crescent moon shape, so they're easily can go on top of each other and get stuck. When this does occur, like I just said, vessels can become blocked and it can slow or stop oxygen being distributed throughout the body. So a sickling event, external sickling event occurs when a combination of extensive or intense exertion and low blood oxygen in the body. When a sickling event occurs, individuals can experience muscle cramps, difficulty breathing, dizziness, and even muscle weakness. So when this does happen, so the first thing that you want to do is stop that athlete or that patient or whoever from whatever activity that they're doing, and have them rest and be able to hydrate as quickly as possible, and also give them high flow oxygen since they're pretty much oxygen deprived. So with this study, with this capstone project I've done, I found a mixture of systematic reviews, literature reviews, case studies, observational studies that explain what sickle cell trait and sickle cell disease actually was in a physiological standpoint. And it also showed some stats on sickle cell death with sudden death and with when pre-screening is utilized and when it's not utilized. I also use my personal experience with sickle cell trait and being an athlete, because I do have the trait and it is something I've been struggling with and I still struggle with to this day. So the results that I found, sickle cell trait, of course, since it is that 1 in 12 chance in African Americans, you do see that more in the athletic population rather than sickle cell disease. I was, unfortunately, I was limited with the different sports that had a sickle cell trait or sickle cell disease athletes. The only articles I really found were the NCAA football, since that is like a really big population of African Americans that play that sport. Unfortunately, I was looking for some basketball, but I really didn't find anything. But what I did find in those research articles is that sudden death in sport is predominantly seen within the Black athletic population versus other races. And this is, like I just said, you see it more in the football, in NCAA football. So I recently got turned to this article that I think it was published in April of 2020. It was an article that was going through like the differences of the sickle cell, the people with sickle cell trait or sickle cell disease participating in sport, either having the like the pre-screening with the sudden death, and those when they did start the legislation in NCAA how fast that decreased. So after the pre-screening for the sickle cell trait and the sickle cell disease was added to the NCAA in 2010, there was a 89% reduction of risk in sudden death, which that is like huge. After that, just adding those questions into the pre-screening regimen. So the big take homes I want you guys to know is that I believe that a lot of all athletic trainers and other healthcare professionals need to be aware of sickle cell trait more and need to talk about it more. They also need to be able to recognize the signs and symptoms of a sickling event. So it doesn't take somebody laying on the floor cramping or something really bad for them to start getting their plan of action in order. And also being able to make sure that they have the necessary equipment that's make sure that it is present in case of an emergency of a sickling event. Personally, I haven't met anybody else who has a sickle cell trait or sickle cell disease other than myself, which I think that falls into the problem of today, because I don't think enough people talk about these two common diseases that you see in athletics. But I said that I believe that the lack of that familiarity of this condition can lead to misfeasance easily. Just in case, so like I just said, if somebody's on the ground or they're having issues breathing, somebody might not be able to know how to treat that if that situation happens. So in conclusion, I do believe that more conversation and learning needs to be done with sickle cell trait and sickle cell in athletics and in all healthcare professionals. Recognizing the signs and symptoms of distress within an athlete for sickle cell trait and sickle cell disease is dire and potentially saving a life. And unfortunately, I really didn't find a lot of articles saying that pre-screening was done in high school, but I know for my athletic background, when I was in high school, we didn't have any type of screening. They didn't ask me any questions about anything with sickle cell trait. Even if it was in my doctor's note, they still did not do anything about it for like a pre-participation exam. So I believe that high school should adopt what the NCAA is now doing, since it has shown a great potential of helping decrease the sudden death in athletes. I want to say thank you to Dr. Brybeck and Dr. Newsham for your help with this presentation and everything that you have done for me throughout this program. I really appreciate it. And these are most of my references that I use. I have a couple, but these were the ones I want to highlight. Thank you. Any questions?
So when you're having you can pull from your own experience in the literature, what are the chief complaints when someone is going through a sickling? What are the key features that are either complained of or observed?
So with me personally, my stomach just like cramps like really, really bad. And I have some trouble breathing. I do also feel like my legs get a little weak. Like for instance, I'm doing therapy still. So they have me running for 20 minutes on a treadmill. Honestly, Tony, when I'm 5 minutes into that, my stomach is just like killing me and I have to stop for a minute. I've also had moments where when I was playing basketball and I would just ignore the signs. And I would get to the point where I would just like start sweating like crazy. I can't breathe. And then I would like have to throw up. Or if I get sick, I feel like I'm about to pass out. It's gotten to that point too. So yeah, it's not fun.
So what does the research tell you that needs to be done to manage that?
Definitely the pre-screening is the first step. And then if a sickling event does happen, definitely pull them from the sport, make sure you have your oxygen there ready for them. So that's the first thing besides just like hydrating them that you should do is the oxygen, because that's what they're being deprived of.
Any questions? No? Okay.
Okay, next is Iris, and she's going to talk about adapting to the new normal considerations for athletic trainers. during COVID-19.
Yeah, that's a poster. Make sure we go back there. Get them in the back.
Okay. Right. So like Gabby said, I'm going to be talking about some considerations that athletic trainers should have now that COVID's a thing. So by the end of this presentation, you should be able to recognize ways in which the athletic training profession has changed after COVID, apply some research considerations to COVID procedures and policies, and compare current return to play protocols to COVID return to play protocols. So as you all know, along with the numerous changes that came with COVID, the profession of athletic training also changed a little bit, and our roles kind of shifted and evolved. When the pandemic hit, the versatility and resilience of athletic trainers really showed through as ATs filled the needs of our healthcare system. They put their skills to use in non-traditional areas of practice when they weren't able to be in their usual settings. And they ultimately gathered some new job duties and skills such as contact tracing. And the crazy thing is that we all kind of were right side by side with our preceptors as they were navigating through this new normal. I know that some of my classmates were doing COVID testing, and then others helped with like the COVID questionnaires. I had a summer experience where kind of all we focused on was the logistics of getting students back to sport, back to school in a safe manner. And so because COVID affected a lot of our experiences, I thought that it would be good to base my project on some important considerations and important information that we should have that's going to affect the way that we practice once we move on from here. Okay. So to kickstart my project, I actually first sourced a lot of news articles that were reposted by the BOC, and I did that in an effort to find AT experiences all across the country. And then from there, I took notes on kind of what was discussed the most. Then I went to PubMed to find research articles and journals that kind of had information pertaining to those topics. Then I synthesized all this information and made a little infographic poster with that like contains and highlights the key takeaways from this research, with the goal of creating a quick reference for ATs to have that's easier to use and like access than reading a whole paper. And so from all that research, I kind of found that ATs should create COVID response teams. They should review and update their pre-participation exams. They should review and update their emergency action plans, assess the risk of transmission, then mitigate that risk of transmission, prepare and plan for heat acclimatization and conditioning, and then monitor return to play after an athlete has come back from having COVID. So then here is my project as you all have in front of you, but then also you can look here on the screen. And as you can see, it has all those big topics that I had in my last slide, and I'll go a little bit more into detail on each one of these. So the first one is creating a COVID response team. So athletic trainers should create this team where they're gonna collaborate with a physician, a public health official, an athletic director if they're at a secondary school, also a nurse, to be able to protect the health and safety of students and staff. And they're gonna do this by staying updated on current information. They're gonna develop, implement and policies and procedures to mitigate the risk of infection, and then develop protocols to follow if they do have infection, or also if they have like a rise in cases in their community. And then moving on to PPEs. So as we all know, pre-participation exams are like the first line of defense that athletic trainers have to keep individuals safe during participation during sports. And to be able to continue to identify conditions that might predispose an athlete to sudden death or injury, it's imperative, it's really important that COVID-related history and symptomology be added to the medical and family history of these COVID or of these PPEs. And I think at this point, we kind of know a little bit about how COVID affects our body, but not, like as Maddie was talking a little bit, not so much. I mean, there's still so much research to be done after this. So I think that if an athlete has a history of COVID-19, they might have a silent clinical pathology that can increase the risk of injury, illness, or even death. So we really have to watch out for those post-COVID complications. And then on top of that, it's really important to identify these conditions that might place an athlete at a higher risk of complications if they do get COVID while like playing a sport, such as obesity, lung conditions like asthma, diabetes, high blood pressure, on top of so many other things that are also on that poster. And then, we also have to take into consideration what sport the athlete would be playing. A golfer is definitely at a lower risk of getting COVID than a wrestler would be. So take that all into consideration when an athlete wants to play a sport. And then that last bullet point there is to review, update, and practice the EAP. Because we don't know quite well like the effects of COVID, there might be cardiac, respiratory, or neurologic emergency events that might happen. So you always have to be ready for those. Okay. So mitigating the risk of transmission. ATs have been an integral part of this since the pandemic hit. They've been doing things like administrating COVID questionnaires, doing temperature checks, and even changing things up like putting the taping tables like 6 feet apart to support the social distancing guidelines, setting up appointments so that it's one-on-one, also limiting appointments like 15 minutes to reduce that exposure. A lot of ATs actually since the pandemic started to do a lot of telehealth, so doing that. And they've also been cleaning a lot with registered disinfectants, bleaching solutions, and alcohol. Okay. So going into heat, forgive me, this word is very hard for me to say, acclimatization and conditioning. We know that a period of acclimatization is important to reduce the risk of getting a exertional heat illness. And during this time, it's more consideration has to be given to this process because because the incidence of injury and death increases when transitioning from a period of inactivity to regular training. And we know, and we've been seeing a lot of like long periods of inactivity when kids or students and athletes are going into quarantine or isolation. So before COVID, this process usually took 10 to 14 days. And then after COVID, it's actually suggested that this process take 17 to 24 days. The first 10 days are really focused on improving that aerobic fitness through endurance and circuit training. That's done indoors. And then the next 13 days are really dedicated to that heat acclimatization. Okay, so breaking it down a little further, day 1 through 5, you're doing 45 minutes to 60 minutes of activity at a 60 to 75% heart rate max, or a rate of perceived exertion of 13 to 15. Day 6 to 7, you're doing the same thing. The only thing is that you can increase the time to an hour to an hour and a half. Then day 11 to 15, you're doing one practice that's going to last a maximum of 3 hours. If you are in a sports intensive or equipment intensive sport, then you can do a helmet but no contact. And then day 13 to 15, you're doing helmet and shoulder pads and moderate contact. Then day 16 to 24, you're doing full equipment, full contact. Then it's split up. So on the even days of the week, you're doing 2 practices, 5 hours max practice time. And then on the odd days, you're doing 1 practice for 3 hours max. Okay. And then diving a little bit more into the conditioning and reconditioning part, it's actually suggested that you follow the 50, 30, 20, 10 rule. And this gives you a recommended percentage of weekly volume and workloads for conditioning in the first 2 to 4 weeks of returning to training after a period of inactivity. And it's based on the maximum level of, or maximum volume of the training program. So then if you're gonna do like 100 at the end of the program, you're only starting at 50 the first week. Okay. So if you do have an athlete that gets COVID-19 and they go through the allotted time for isolation, which is usually 10 days, they may begin their return to play progression. And it actually starts off with a doctor doing an evaluation and then clearing them to start the return to play progression. And as you can see here, so this one's actually the one that they use at my clinical site. And I think Mercy might have developed this. You can see there that it includes a cardiac screen, and you have to like get a nose on all of those. And if you do have a yes, or the athlete was hospitalized for COVID-19, then further testing is required before they jump into this progression. So once they do get cleared, you go into this 5-stage progression. The athlete has to progress through each one of these stages without having any of these symptoms. So they can't have chest pain, chest tightness, palpitations, lightheadedness, pre-syncope, or syncope. And if these symptoms do develop, they have to go back to that doctor to be evaluated further. And you can see there, so that the first stage is going to be a 2-day minimum progression, and they're going to be doing light activity. And this is only going to be for 15 minutes or less and no resistance training at all. And that stage 2, you're going to add some simple movements, and you can do it up to 30 minutes. Stage 3, you're going to progress to some more complex activities and complex training. You can do this for 45 minutes or less. And at this stage, you can add light resistance. And then stage 4 is another 2-day minimum, and you're going to be doing normal training for an hour. And then that last one, just full return to activity if they've gone through all of the other stages without any symptoms or complications. So in conclusion, as ATs, I really saw during our clinical experiences with our preceptors and all the practicing ATs, how we have a really unique ability to use our diverse skill set, which integrates prevention and rehab and emergency care to help bridge policy with practice in whatever setting you're in. So it's really important for myself, for us, and for all the practicing ATs to keep some of this information that I shared in mind moving forward to ultimately contain the spread of COVID, ensure safe return to activity, and promote overall wellness and health. And then this last bullet point is kind of like a little thing to Kate's presentation as well. There was a lot of mentioning of taking care of yourself in all of the news articles that I read. And so with all of the information that's coming out about COVID, and everything's changing, new roles are coming on, more hours are being added on to the workload that athletic trainers have. It's really important to take care of yourselves as athletic trainers, because you can't care for others if you can't care for others in the best way if you are yourself not healthy. Thank you to Dr. Breitbach for all of his support with this project. And then if you wanted to, my resources. And then if you wanted to reach me, there's my stuff.
So tell us about the infographic. So is that all original artwork, or did you pull that?
No, those are clip arts.
Clip art, but I mean, was it from articles about COVID, or was it
Oh,
kind
no.
of just like the little graphic creator thing?
Yeah. Just a little graphic creator.
So you pulled together a bunch of different resources for that?
Mm-hmm. Yes.
You did a very nice job of this.
Thank you. Thank you.
Any questions or anything for Iris? So what do you think is the one take-home point you learned? Because obviously everybody in this room has gone through this crazy world we've got for 15 months. What is, when you look back on it 2 years from now and you're not working, everybody's normal, what is probably one of the most vivid things you remember from this year?
Pertaining to COVID?
Yeah, pertaining to COVID or pertaining of your clinical experiences?
That's a good question. I think that, so over the summer, when everything was opening up, I was at a clinical site. And this is where we really just focus on logistics. I think if I was looking at this 2 years in the future, looking back, I would think, oh my God, that was so much work. We put in so much work and so much thought process went into like even the littlest things. Because I think as an athletic trainer during this time, you have to think about like the smallest things that will affect the health of other people. So I think that's what I would kind of like reminisce about, was all the hard work that went into the smallest details of putting together like policies and procedures and rules, and even like implementing and watching and making sure people have their mask on over their nose type of thing. So
Yeah, those are things that in the normal world, athletic students don't get that much access to those types of those kind of policy-based opportunities, and we have to go through that. Any other questions or comments for Iris? Maddie?
I thought your we're just struggling together. Yeah,
Yes.
Yeah.
Conversation.
That was so, I didn't even think about that, but it originally, but then it made me consider in our summer with SLU basketball, we had to do our workouts outside because of like airflow and stuff. And you would never think being a basketball athletic trainer, you have to like think about the heat and stuff, but we were having to highly consider that because in St. Louis summers, it would be, 9:30, 10 a.m. and it was already too hot for our athletes to be outside. So I thought that was very interesting.
thank you.
So introduce your classmate.
Yes. So next we have Kayla, and she's going to be talking about dynamic warm-ups and kind of their effect on injury prevention.
Oh, right. Yes, the pictures.
Move your mask.
Okay, so like Iris mentioned, my presentation today is going to be on the efficacy of dynamic warm-up and how does it prevent injury. So some learning objectives I have for you all is I hope that I can educate you all on the importance of dynamic warm-up, understand how dynamic warm-up can reduce the risk of injury, and describe some different factors that impact the efficacy of dynamic warm-up other than the warm-up itself. So just introduction. So warm-up is considered an essential component of exercise. Unfortunately, sometimes it can get disregarded or athletes will not take it as seriously as they probably should. And then the dynamic warm-up is a little bit more sport specific and prepares muscles that are going to be used in practice or in game. And especially for high intensity athletes or more elite athletes, dynamic warm-up is a lot more beneficial just because it gets those muscles moving. FIFA 11 is mentioned quite a bit in this presentation, but other dynamic warm-ups are created for specific sports as well. And then research studies prove that there is a positive impact of dynamic warm-up for athletes, which is reduce the risk of injury. Okay, so I just want to touch a little bit on what is FIFA 11, just because I do mention it quite a bit. So it is just designed by the Federation Internationale de Football Association, and was specifically designed for soccer-related injuries. So there is a big focus on knee injuries because that is kind of a leading injury that occurs in soccer. So actually, if you can see at the bottom of, but if you can see at the bottom of the poster here, it kind of tells you how to position your knee when doing some of these warm-ups or even just normal practice of soccer. So it is broken down into 3 stages. The first one is just 8 minutes of running. So that's that top section right here. And then the next one is your strength, plyo, and balance. So that's about 10 minutes. And then you end with 2 more minutes of running. So that's just kind of a breakdown of what the FIFA 11 consists of. And it's also in 3 levels. So these columns kind of represent the 3 different levels that the program consists of. And so it kind of helps you understand like the difficulties of each level. Then it is very easy to implement and teach to coaches or strength and conditioning coaches who are guiding your athletes through the warm-up. So it's very like easy, accessible, easy to teach, and pretty straightforward to add into your practice routine. Okay, so then some background on my studies that I've found. So again, as I mentioned, FIFA 11 is designed for soccer athletes. So in this study done by Granelli et al., it focused on ACL injuries in soccer athletes. In this specific study, it was D1 and D2 male soccer athletes. So it was an intervention group and a control group. The intervention group had a 77% lower risk of ACL injuries, and this was done throughout like the entire season. So injuries to the ACL was reported throughout the entire season, and it did not have to be like a full ACL tear or anything. It could have been like a minor sprain. It could have been a non-contact or contact mechanism, and so on. So that seemed like a very large and significant number to me, just done by just compared by the intervention and control group. And then another study done on basketball athletes also used FIFA 11. So FIFA 11 does not have to be just done on soccer athletes. You can really use this program on any sport if you really wanted to. So this intervention group had a decrease in injury, specifically in trunk, leg, and then hip and groin injury. It was surprising to me because in this specific study, there was not a significant difference with ankle and knee injuries between like the control and the experimental group, which I thought was kind of interesting because the FIFA 11 does focus so much on knee injury prevention, that I just thought that was kind of interesting. It could just be the fundamentals of basketball and soccer are different, but that's just something that I noted while doing some research. And then in another study by Padua et al., it does not use FIFA 11, but it uses a dynamic warm-up that is sport-specific to basketball. So in this specific warm-up, it focused on ankle injuries because that is the leading injury in basketball. So the control group for this research study just did their basic warm-up, which was just ball handling and then some core stability. But then the intervention group, they utilized core stability, some ankle mobilization, balance training, and as well as some ball handling as well. So again, there was a decrease of injury in the experimental group that utilized that dynamic warm-up that was specific to basketball. And then just to note, decrease in ankle dorsiflexion was correlated to ankle injuries. And in this study, the intervention group had an increase in ankle dorsiflexion, which is kind of correlated to the ankle injury and why that decrease in injury was noted at the end of this study. And then just some other aspects that I found that kind of assisted dynamic warm-up and how they made it kind of more effective in reducing the risk of injury. So the use of functional screens is helpful in assisting and creating a dynamic warm-up program for athletes. So just a functional warm-up screen is just an assessment tool that you can use to observe the deficits in strength, stability, and mobility. It also just helps the athlete understand some mechanics of their body and how they can correct themselves while doing certain exercises and in their warm-up, just to decrease that risk of potential injury. So I thought using functional movement screens would be helpful to coaches, ATs, strength conditioning coaches, just to kind of understand how that athlete is moving and how they can correct them in moving forward. And obviously it's not practical to cater a warm-up for every athlete, but I think using a functional movement screen for a team and then kind of viewing those results to make a warm-up that suits them or suits that team. So then another aspect that I also found kind of interesting was compliancy to warm up also resulted in a higher risk or a higher decrease, high percentage of reduced injury. So in a study done by Solagard et al., he conducted a study on female soccer athletes that showed that the highest level of compliance of athletes had a 38% risk of decreased risk of injury. So the group that had the highest compliance to the warm-up had a greater decreased risk of injury compared to the low and moderate compliance groups. So compliance to dynamic warm-up was encouraged by these coaches, and they were kind of like the greatest advocate in this study. And they kind of had a big influence on the athletes. It was really interesting because it kind of brought in like a psychological component to just dynamic warm-up itself, because in the study, they mentioned that coaches who even worded their encouragement differently had a impact on how the athletes did. So if a coach said, oh, this warm-up is important versus this warm-up is very important, it actually had a pretty big influence on the athlete, which I thought was pretty interesting. Just like that small little aspect can have a great impact on the athletes. And I think that's because the coach is the athlete's greatest advocate, greatest encourager. So I think the athletes kind of take what they say very seriously. Okay. And then, so methods that I used while looking for research. I did use PubMed, Sports Discuss, and then I reviewed different studies to understand the efficacy of dynamic warm-up. I didn't focus on a single program, although I did mention FIFA 11 quite a bit. A lot of research that popped up was with FIFA 11. So then my age ranges were from 18 to 23-year-olds, so more of the college athletes, and they were an active population. So none of my studies really had like recreationally active athletes. They're like college athletes or elite athletes being studied on. And then I focus on the effects of dynamic warm-up on lower extremity injuries, so ankle, knee, thigh, anything in the lower extremity. Okay, so then this is just, again, a review of research results that I just discussed. So there was just, the results did conclude to be a decrease in injury, and that just dynamic warm-up did have a positive impact and were beneficial towards these athletes. And then in the Longo et al., the basketball study that did use FIFA 11. So they used FIFA 11, but they modified it to add some basketball components. So again, you can really modify FIFA 11 to anything or any dynamic warm-up to whatever sport. So I think that's what makes dynamic warm-up really great, that you can modify it to fit your sport and to kind of, yeah, cater it to the sport that you are working with. Discussion. So I think it's clear that the implementation of dynamic warm-up is beneficial to athletes in preventing injury, just based on these studies and other studies that I've also found. I think there does need to be a greater emphasis on warming up correctly. I know in my clinical site, and specifically, I do observe my athletes, and when they're doing their dynamic warm-up, they aren't doing it to their best abilities that I know that they can. So I think that needs to be emphasized in any setting. And I think coaches also need to be aware of the intensity of their workout, and then that should also kind of correlate to their warm-up. Again, in my personal experience, I know kids will come in with injuries, and then they'll mention that their warm-ups got increasingly harder that week, and then that's kind of when the injury comes up, is when there's an increase in intensity, but they weren't warmed up correctly, or they just stayed with the same warm-up they've been doing all season. So then just some limitations to my search. I did not focus on a specific sport or specific injury, but I think that would have just strengthened what my research, if I focus on those two. So then in conclusion, dynamic warm-up is shown to reduce the risk of injury just because it is more sport specific and adequately warms up the muscles. And then factors of consistency, compliancy, and also just correct technique should be taken into account and taken more seriously. I don't think warm-up should be skipped. I don't know if anyone is really skipping their warm-up right now, but they really shouldn't be. And it's just essential for athletes to reduce the risk of potential injury. So yeah. So then thank you, Tony, for me and assisting me throughout this entire process. Some references, and then yeah.
So as you move forward, obviously FIFA 11 is a pretty standard used tool as you go forward. What do you think if you go to an institution or a school that really doesn't have any idea what it is and why they need to use it? What would be one of the first things you would say to a coach saying you need to start doing this? What would be kind of your elevator pitch for people?
Of like why we should?
Yeah.
Well, one, it reduces the risk of injury. But also it just, I guess it just, I don't know, it helps the athlete. I don't know, I guess my main point would be it reduces the risk of injury, but it'll, how do I word this? Like the positives outweigh like the time it takes to warm up, or that like right now it doesn't seem that important, but along the line, if you have an athlete who injures himself, they're going to be out for like the whole season. So that itself kind of is what makes me think that you should be implementing these types of warm-ups into your practice routine, just because later down, like it doesn't seem like a big deal now, but later down the line, it can snowball into something a lot worse. So yeah.
It allows them to be more purposeful, right?
Yeah.
I mean, everybody warms up. It's just a matter of some it's a little laissez-faire. Other stuff. This is. Any other questions for Kayla? No? Good job. Classmate.
Yeah, so for our final presentation of the afternoon, Joey Wenzel will talk about does early sports specialization cause more overuse injuries in adolescents?
Oh, let's take a picture first.
Okay. I get my notes out here. I get my notes out. Okay. Yeah, so I'm going to be talking about if early sports specialization causes more overuse injuries in adolescent athletes. So learning objectives, we're going to understand why sports specialization leads to overuse injuries. We're going to be able to describe the different risk factors that play a role in the development. And then we're going to try to discuss some ways to decrease these overuse injuries. So introduction, children are increasingly choosing to specialize in a sport at a young age, despite recommendations not to do so. In 2000, so the American Academy of Pediatrics put out a position statement saying that children need to play as many sports as they want and really not choose just one sport to specialize in. Then in 2016, that was followed by the American Orthopedic Society for Sports Medicine, again, saying, don't do this, don't specialize in a sport, play multiple. Because there are many negative effects specializing. Their burnout is the big one in addition to overuse injuries. So children that specialize become disinterested and then they end up quitting a sport. And then it also can pigeonhole these children. So they are only exposed to this one thing, one sport, while there might be something else that they do or enjoy doing more so than just that. And then parents and coaches believe that sports specialization could lead to elite status and help these kids get a college scholarship, play professional, make a lot of money that way. But there's no evidence that that is the case. So before we get into the meat of the presentation, some quick definitions to kind of help you understand what I'm talking about. So sports specialization is playing a sport for more than 8 months of the year at the exclusion of other sports or activities. And there are different degrees of specialization. So answering yes to any one of these 3 questions changes the degree. So the more yeses you have, the higher the degree. Is the first question, can you pick a main sport? Did you quit a sport to focus on this main sport? And do you train more than 8 months out of the year at your main sport? Then adolescent is a person under the age of 18. Most of the studies I have focus on kids in the range of 10 to 18 years old. So my search, I went on PubMed to find my articles. They were all recent in the last 10 years, all published in English, and all, of course, had that adolescent population. I didn't want anything that didn't have a sports specialization aspect to it. Again, nothing that didn't have the overuse injuries, but I did find many of the articles mentioned acute injuries as well as overuse, and then no adolescent patient population. This led me to 10 articles, 2 systematic reviews, 2 cohort studies, 4 case control studies, and then 2 surveys. So the results, as you might have guessed, the degree of specialization does correlate to overuse injury rate. So the more specialized, the more likely you are to suffer an overuse injury. So between the highly specialized that answered yes to all 3 of those questions, you are 81% more likely to suffer a overuse injury than low specialized, and 18% more likely to suffer a overuse injury than moderately specialized. So 3 compared to 1, and then 3 compared to 2 yeses. And then if you answered yes to 2, so moderately specialized, we're 39% more likely to suffer an overuse injury than the low specialized. And a serious overuse injury were 1.9 times more likely to occur in the highly specialized group of athletes. So, and then different sports have different rates of overuse injuries, as you might guess. So found that individual sports have more overuse injury than team sports do. I believe this is due to just the individual attention that the athlete receives during practice and competitions in that. So males, I found had an increase in baseball, gymnastics, and cheerleading in overuse injuries. And then there wasn't really much of a difference in total rate between basketball and soccer, and then all other sports. So those are pretty much the same. And then there are differences based on your gender and sex. So females are more likely to suffer an overuse injury, except for when you take into account the hours that they practice. So then 3 to 4 less hours per age for females,
resulted in a higher risk of injury. So that is when they practice 3 to 4 less hours per week than their age. So, 15-year-old practicing 15 hours would be 1 hour per week, or yeah. And then female basketball players are 4 times more likely to report an overuse injury than male basketball players. Was mentioned in one study. And then age was not much of a factor in males, and then it actually decreased in females. So the older the females got, the less likely they were to report an overuse injury. And then time spent, I kind of mentioned that a little bit already, but the time you spend practicing and playing is a strong predictor of the overuse injury development. So the weekly hours compared to the age is what most of the studies use to kind of see how that worked out. And then also there was a couple of studies that mentioned free play in addition to the organized sports. And they found that a 2-to-1 ratio between the organized sport time and free play time was another strong predictor of risk. So if you're over that 2-to-1 ratio, you have a much higher chance of developing overuse injuries. And then the sports that the time was a big factor in, cheerleading and gymnastics, which are both individual sports, kind of tying back into that. And then baseball in males was another one, and volleyball in females was another one where the time really made a big difference in that. And then serious overuse injuries, again, 2 times more likely to occur if you spend more time practicing than your age. Then the acute rates are very similar. So while people are having more overuse injuries, the acute injury rates between the two are very similar. One study I found said there were 44.7% of the injuries that came into a clinic were overuse injuries, and 41.9% of those injuries were acute. So no difference, or even a lower risk of developing acute injuries. So some things that we can help do as athletic trainers to encourage and help delay this thing, we can encourage the athletes to not specialize in a sport so soon. So high school athletes, have them practicing maybe 2 sports, playing 2 sports if they're able to. But we really want to encourage multiple sports and have them playing more free time. And then the hours spent, like I said, strong predictor. So we want to lower the hours that they spend practicing, so they have more time to do other stuff, have more rest, because the rest period is a big thing, and they could help delay and even prevent some of these overuse injuries. And then more free play time, so they're not so regimented in practicing those same motions, get them out doing some other stuff. And then all of these studies I found were retrospective studies. So if we could, future research purposes, maybe some more prospective studies, picking a group of kids, or looking at one sport in particular and following kids as they age and grow up, and seeing if they develop these overuse injuries, and seeing if a sports specialization is one of the reasons why. So conclusion, we learned that sports specialization does lead to more overuse injuries in these adolescent athletes. Don't think that's a surprise to anyone. Really, it makes sense. They're playing one sport all the time, doing the same motion, puts repetitive strain on the body parts that they use, and that leads to injuries. There are many different factors that contribute to this. The degree of specialization, the time spent practicing, and their sex even plays a role. then there are ways we can help to decrease this risk. Encouraging more free time, less practice time, and then just having them play multiple sports, doing other things besides focusing on that one sport. I want to say thank you to everybody that helped me out along the way, all my professors, my parents, and my preceptors. My references, and if you want to contact me.
Questions? I think we have one in the Q&A, or Mike Marquis can ask one.
Yeah, so about the specialization unrelated to injury, is there a common factor among sports that lend themselves to being more specialized? Yeah. Like you don't, like you hear about soccer players always starting at a young age, but you don't hear about, you know, track athletes starting at a young age. I mean, is there a common factor about what kind of sports lend themselves more to specialization than others?
I didn't really see much of that in my research. It did mention that gymnastics in individual sports, so sports where you're not playing as part of a team, see a lot more specialization at younger ages, but I didn't see really anything in regards to more specific than that.
And then we have a question in the chat from Tim Hall. Are kids choosing to specialize in a sport, or is that a decision made for them by their parents?
From what I read, the parents and coaches are the main drivers of this, but I'm sure the kid would have some choice as well. But I didn't see, there wasn't a whole lot of discussion on that.
So as you worked on this, and you look at going out into the workforce, and so are there certain things that you picked up where, someone might be coming to talk to you? What would be the first thing that you would tell them about that they're thinking of quitting? For example, thinking of quitting basketball to play travel baseball or something like that. What's one of the things that you would tell them?
I would ask them why. Like, is there, like, you just not enjoy playing basketball anymore? Or is there a specific reason why you want to quit it? And then I would, if there's no really reason as to why they want to quit it, I would encourage them to continue to play both, because basketball and baseball take place in opposite seasons. Baseball is a summer sport, basketball is a winter sport. So I think playing both is something that you could do easily if you wanted to.
Any other questions? Congratulations. Good job, everybody. Let me do a couple little logistical things here really quick. And we are going to go into the kind of the second part of this right now, where we are going to recognize all of you. We have some information for you, but to get started, what we'd like to do is we would like to start with Lisa Dorsey, our department chair, would like to say a few words. Kristen, could you do me a favor? Could you change the spotlight video to that camera, the room camera? Oh. I can do it. I want this to be able to be captured, so, okay. You're gonna, can you stand kind of right in here? I'm going.
On the X?
No, it covers a pretty large area. Yeah, you're okay. Okay.
Well, hello, everybody. I can't go without commenting on the last presentation and your question, Dr. Hall, because I'm constantly, I have two sons who are very, very busy, athletic young men playing multiple sports for multiple teams all the time. And we constantly get pressure from his soccer coach that he should only be playing that, not baseball and hockey. And I have this argument with him all the time that, you know, it started when he was 11. Like, no, he's 13 now. He still plays all of them. I think it's healthy. It's good. It's hard on me. Harder on me than it is on him. But so the last presentation really resonated with me as I'm like the overuse piece and multiple sports and the specialization pieces. But happy Friday afternoon. What a great way to spend your Friday, being able to bring this all together and benefit from one another's inquiry in this milestone activity that kind of culminates what you've done and where you're going and the good things that you're going to bring to the profession as you move forward. So I appreciate really all the level of inquiry and the thought process around what you know with regard to your topic, what you learned along the way, and how you're going to apply that whenever you go out and begin to practice, and are telling us parents what we need to do and how we need to do it, and really informing us and all of our other professionals, coaches, et cetera, in the ways with which the literature continues to inform us based on the good work. So congratulations, everybody. And you know what this means, right? This means because you've completed this part, you're really close to just being done, right? So again, congratulations. Thank you for the invitation to be able to come say a couple of words. And now you guys can kind of heavy sigh and enjoy the rest of your evening. So thank you.
Thanks, Lisa. With the other faculty mind coming up, we're just going to introduce everyone and allow you to greet them as we go through. So
There are enough X's up there for all.
no, we don't. Yeah, I think.
Okay.
Yeah. So what I'm going to do is we're going to give you the chance to just get a chance to see us all as we go out. And in these envelopes, we have your certificate saying you've completed our program. And we have a copy of your composite photo for you. And then we're going to go through all of you at the beginning. And then Mike is the chair of the awards committee, is going to recognize a couple people with some of the awards. Okay. Yep. So we'll start out with Jose Blanco. You want to start with Katie and work your way across? There we go. There you go. Good. You can take your envelope with you if you want. Eddie Bozic. You can share your across our shoulder. Marie. Congratulations. There we go. You got a funny name there. Gabby Heron. Be shy, guys. Each other.
Thank you, sir. Thank you.
Hey. Iris Herrera. Josh Hicks. Joshua Daniel. Congratulations, sir. Kayla, Melanie with 2 hours. Kate Kirkhope.
Yeah.
Last but not least, the W, Joey Renzo. Okay, so we're gonna let Mike, you go to the floor.
All right, thank you. As you may or may not know, the awards committee is comprised of 5 individuals, including faculty, staff, and friends of the program: Paul Nativi, Sherry Ashford, Kevin Clear, Tim Howell, and myself. The committee meets throughout the year to elect individuals that stand out in the program. The awards include academic excellence, community service, professional service, and clinical excellence. The Academic Excellence Award is determined by the student with the highest GPA in the professional phase of the program. This will be determined at the conclusion of the semester. The Professional Service Award is given to the individual who has excelled in service within the field and within the program of athletic training. This includes involvement in SLACs, Iota Tau Alpha, tutoring, and involvement in state and national organizations for the profession. The award this year is given to Kate Perko.
So how about we not have anyone in it with her so she can take her mask?
Oh, okay.
My mom will appreciate that.
Yeah. I always forget all of that.
Congratulations.
Thank you.
Yeah. Okay, the Clinical Excellence Award is given to the individual who has achieved excellence in a clinical setting. Nominated by his or her preceptor, the individual excels in communication skills, athletic training skills, integration, and a commitment to learning. The award this year is given to Maddie Bozich.
So, yeah, we do have a community service award, but people need to apply for that.
Yeah.
And no one applied for it, so. But try hard. Try hard. So, once again, congratulations, everybody. We will have pre-commencement on the 20th. We have some exit interviews. We're looking forward to that. Make sure you finish your assignments, right? You have assignments left. Exit survey, course evals, your end of the capstone reflection, right? You got all that stuff. Corey, we have a tradition of taking some group pictures with you all when we're done. And Corey's pretty good at it. He's done it for a few years in a row. So what we're going to do is usually we kind of stand over there, right? Because that usually where we are. So, but anyway, congratulations. And we're really proud of you. It's been a heck of a run for you all. And to be in this position. So, Sam, Kitty, do you want anything you'd like to say to them? Like we have them here?
Yeah, you on campus next Thursday? Get a notary stamp on any license applications that you